All right, I think we are good to go. Sorry for the delay. We were just working on who was going to do the introduction, and I'm going to do it myself. Thank you all for joining us. This is the monthly event that we hold, and it's the the focus is really on existing users, so people that have the Digital product, the system, and I use a specific case example as an opportunity to review the analysis, right? So, how do we look at the analysis, the data that we collected after the result of an acquisition, successful acquisition, and how can we potentially use that information to um, work with our clients or our patients? And so, this month, this event is looking at low back pain. And I know a lot of people, I get this question actually quite a bit, and they're thinking, well, why low back pain with gait analysis? So, first off, I like to call it locomotion analysis and not necessarily gait analysis. But let me pull up something that I have written um, as part of the clinical guide. So, if you're ever looking for something like this, let me know. But just a quick screenshot. So the reason for this is I highlight, as the literature shows us, what types of things are affected in gait, or again, to use locomotion. And the reason I do that a lot is, people think gait is very specific, sort of to the lower extremity or the feet. And here we're really talking about the torso. So things that we may find in chronic low back pain, also considered non-specific chronic low back pain. You'll see some changes in symmetry and walking speed, as well as strategies in how people go through the walking cycle from the contact into the swing phase. So there are going to be some strategies, and we're going to look at a case here in a moment. And part of this is because of center of mass issues. Oftentimes, there's a change in some of the anatomical features due to antalgic positions. They're trying to walk with less discomfort or pain, and so that can change, part of their gait profile. And then we also tend to see some variability issues in all of these patterns. And so we will look at our system certainly and look at the output. So this is going to be very specific to the Digital system. So let me pull back up my screen here and let me pull up my case in point. So this is actually a patient I just started with, in fact, yesterday. So I don't have a lot of follow up yet, but great example. And those of you that might know me, and I apologize, I completely forgot that. If you don't know me, my name is Chris Prue, and I'm the director of education at Digital. And I am also a practicing clinician here in the United States, in the Northeast, New Hampshire. And I also have a background in research and laboratory experience, and specifically in biomechanics. So that's why this product really has drawn to my attention. So I literally just showed you some of those factors that you may see. You don't see them all, and that's, I think, why it's important that we have the appropriate data that we can use to establish some of these parameters, because that's what makes it challenging if you don't have a system that is sensitive enough and with enough variables to actually be specific in determining whether or not your patient actually has a condition. So when we pull up, and let me take a step back here and go to the home page, I like to use my online application a lot. When I'm initially showing patients, I do use the application on my mobile device, and then I usually have my discussion with patients when I'm on the computer, because it gives you a little bit more information and it's a little bit easier to navigate. So you can click on patients, and I have multiple, as you can see across the screen up top here, I have multiple screens open, but I have multiple versions here. So right here, we're going to pull up this particular patient. I click on the patient, and it shows you the analyses. Um, and you choose the analysis that you want to look at. And we can see here that across the top, we've got the symmetry, cadence, and the speed. And actually, I had him at 2 miles per hour. And let's say I wanted to go back and choose another one. So I've got a few options that I can choose from. So I took a couple of different tests here because we had a couple of different pairs of shoes, and I wanted to look at the shoes that he's going to wear the most. And so we ended up with this one. Now, let me take a step back too. So you really have two options because the system is not tethered, right? You're not connected with wires or limited to stepping in a certain sequence or in a certain area. So you can do overground walking or you can do it on a treadmill. I chose to do this on a treadmill because I wanted to control the speed to evaluate the influence of speed. A normal adult should be able to walk at approximately 3 miles per hour or 5.1 kilometers per hour. And so speed is an interesting metric because it actually gives us a lot of insight to the overall health. So, for example, if I have a patient that cannot walk at the average speed, that actually indicates that they do have some health issues and it's related to a reduction in their quality and their length of life. And people can really resonate or assimilate with that. And so it's a really good point to make to your patients that, something needs to happen, something needs to be changed. So across the top here, you can put in your pains, walking aids, and shoes. You can also do this in the mobile device as you're getting ready to take that analysis. So you can do it either time. It's fine either way. I recommend actually doing it. People like myself, like I have patients that I see for years and years and years. So sometimes they come in with different conditions. And so I want to note that so that way, I'm not comparing if they came in with low back pain to when they came in with a shoulder problem or something like that. The main part here on this dashboard is we see that symmetry, cadence, and speed. So I've kind of already talked about speed. Now he's low at a slow walking speed because I did that on purpose. And I'll tell you more about the patient as we move along here. But I wanted to start him off at 2 miles per hour because most people should be able to handle that. Now, the downside of doing that is I do not get to see what his normal comfortable speed might be. So that's one of the when you look at the pros and cons, the benefits or the lack of benefit when you're either using a treadmill. Using a treadmill, you can have people go for really long distances without having a lot of space, but you're not going to get their exact comfortable walking speed. But in any event, it's a variable sometimes I like to control. So symmetry, the symmetry characteristic, and if you put your arrow over the question mark, it tells you the definition of what that metric or biomarker is going to be. So this percentage is going to be calculated based on the stance phase. So it's the duration, the amount of time that the person spends in contact with the ground. And it's going to compare that between the right and the left. So we like to see not perfect, because that's actually, it's not only, somewhat unusual, but it's technically not the best thing either. We like to see some differences in symmetry as well as some variability even on that same side, because that means that they have some buffer zone. They have an opportunity to respond to a changing environment, right? So one of the things that happens with people that have chronic conditions, if they've had it for an extended period of time, is they've worked really hard. The physiology doesn't change, but the effect of that physiology, especially the neurology, changes to where we are naturally attempting to be somewhat symmetrical between the right and the left. And that's what's interesting if you've been doing this a while and you collect this kind of data. And the reason I like to use walking so much is that walking incorporates all of the systems in the human body. And if we think about walking as this timed execution, right? So as you are on stance phase on one foot, and there's a sequence of events that you go through to eventually get into the swing phase on the other foot. So there's what we refer to as a lot of cross crawl patterning. So some of it is voluntary and some of it is involuntary or more so reflexive. So that's why it's kind of a unique internal look to how the person's actually responding to something that they really should know very well because they've been doing it since they were a kid, right? So symmetry, if we look at, it's in green here. So green means that it's within those normative values. So the benefit of having a system that is an AI-based platform, artificial intelligence, is that it not only tells me that they have something wrong or something right, but if it's something wrong, it actually doesn't necessarily designate that which one it is without artificial intelligence, but with artificial intelligence, it says it's either the right foot or the left foot. And what's unique is when we look at the walking profile here in a moment, it actually tells me if it's above or below. And that's the benefit of having that artificial intelligence system. So when I see it in green, I don't have to spend a lot of time on that. We were just having a discussion with another clinician, and they were like, we can't spend a lot of time. Our clinicians can't spend a lot of extra time, and um, can't spend a lot of extra time doing these analyses. And I said, well, that's the best part of the system, is it doesn't take that long. And I know this is going to take me about 30 minutes to get through, but when I'm doing this in front of a patient, once you get good at it, it's like any other test that you practice and got good at. When I'm reviewing a radiograph or an MRI with a patient, I can go through it relatively quickly. But so this is the benefit of this platform: is green means good, green means go, move on to the next one. This amber color means that it's approaching, so it's on the outside of the normative values and is approaching an abnormal value. And so I may want to take some time and look at that. And then the red means that it is outside of the normative values. So where do we get those values? They're normative values from the literature or the system that are embedded inside of the software that help to dictate this. And that's why it's important that when you're putting in your information, that you put in the appropriate demographics of the patient, right? Because this patient is 60 years old and he has a certain height, weight, and shoe size, and all of those factors are characterized within the algorithms that provide us some of the outputs in the biomarkers, especially. So we see that he's only walking at 2.0 miles per hour. Again, I already told you that. I did that. I set the treadmill to walk at 2 miles per hour. And so that's why he's walking a little bit slow. I already know that. That's okay. So I knew that, I'm the one that put him in the red. So let's go ahead and look down here. And we saw that, has a very similar symmetry. He was at 99%. So I would still look at this relatively quickly. But here's what's interesting is he has a stride on the left of 35 inches, and he has a stride on the right of only 32 inches. So that's pretty significant. And we would say that his stride is also relatively short, but again, we were keeping him from walking too fast. So the typical breakdown or average percentages that you'll see is the 60-40, 60% in the swing, in the stance phase, 40% in the swing phase, and there's a standard deviation of 5% in either direction. In other words, 65 and 35 or 55 and 45, you may see something like that, especially as they start to walk faster or slower. And in this case, he walks slower. So we're going to see a little bit more time in that stance phase. It was equal though. But what's interesting is it was equal, but yet we see a relatively, large difference when it comes to his stride length. So I'm going to want to look at that, and I'm going to want to break that down. So this is another component of the artificial intelligence system: is it uses a graphical representation of the colors. And so if it's within green, it means it's within the normative values. And then if it's amber, it means it's approaching outside normative values. If it's red, it means it's going to be an abnormal value. And that's what's interesting about our system, is it actually tells you if it's normal or abnormal, but it also tells you which side it is, and it tells you whether it's above or below. So we do see that his stride duration is just approaching on the slow side, which again, I told you we had him walk slow. Here's why. So patient is 60 years old, male, long history of low back pain. He's had a bilateral iliofemoral arthroplasty, which means that he's had both of his hips replaced, and that was approximately 10 years ago. Um, he's had some ankle injuries, especially on the left side, and he contracted COVID about 4 months ago, and it affected his respiratory system. So he was bedridden for approximately 4 weeks. And so he experienced some other issues and a lot of edema and swelling in the lower extremities, started to begin and experience some radiculopathy, especially on the right side, which is interesting. And so he became mobile again approximately 3.5 weeks ago, but he's still experiencing some low back pain. Apparently, this has happened before, but it tends to go away. So that's kind of the background of the patient. And then we can see that his swing time is actually really, really short. But here's what's interesting is that when we look at the swing and stance times, they're actually coordinated. So swing time is really, really short, but yet his stance time is within that normal phase. So in other words, relatively speaking, he's moving his legs pretty quick to get through the swing time and prefers to be more in that stance phase. Now, he even had some challenges in walking on the treadmill. So first off, that's another downside of using a treadmill. If you don't use a treadmill, if you don't walk on a treadmill regularly, it can be a challenge because it removes part of the effects of normal walking, right? The horizontal component to balance, for example. So that's why we took multiple tests and make sure that he felt comfortable with it, and we make sure that he's perfectly safe. Okay. So let's look at his gait line. So the gait line is going to be the center of pressure through the stance phase. And so what we see here is this is heel strike, or also known as foot in, and he does actually heel strike. And then we go into foot flat, so that's when the toes come down to the ground. And then the next dot is going to be when the heel lifts up off the floor. And then this shaded area, this is the transition that shows us where the position of pressure as he's going into the propulsion phase. Okay. Now, what we also see down here is it's broken down into percentages. So there is normative data on this sequence of events, and we see that he's in green on that left side. So his loading time is normal, and then we see that it's elevated in the foot flat and it's reduced in the propulsion. This is actually not that abnormal because, again, remember that we made him walk relatively slow. So he's not that far off. What I like to see is we are supposed to heel strike with a supinated foot and an inverted midfoot and heel, the calcaneus. So he's actually pretty neutral, and we'll look at the pronation supination here in a moment, but I'd rather see this center of pressure over here, at least on the heel strike, and then maybe transitioning over. And we'll have to look at pronation and supination and look at what that foot really was doing in the foot position, because this is just looking at center of pressure or an estimation in the center of pressure. And so we want to see what the foot position really was like. Over here, we're going to look at the propulsion rate. So the propulsion rate is the ratio between the hip flexors and the plantar flexors, right? The lower leg on push off. And it's calculated with an algorithm. And so the reason we look at this is there's supposed to be a certain ratio, and the hip flexors drive that leg forward, and the plantar flexors also push off to assist in that process. So one of the things that happens with older adults, for example, is they tend to have a strategy where they reduce hip flexor activity and they're using a lot of plantar flexors. Now, one needs to ask the question, is it just because they're older or what's going on? Well, there's actually another association to age, which is a decrease in core stability, right? Activation of the musculature which within the torso. That muscle activation in the torso is really important because that is what's going to respond to the ground reaction forces during ambulation, during walking, running, or jumping, to maintain an upright posture position. So, what happens is the lack of core stability means that they're going to have that strategy. The other thing that we tend to see is there's another strategy in patients with low back pain. They tend to have a reduction in um, core engagement, especially in the hip flexors, because it either causes them pain and or it's also going to be potential weakness. So often as a result of that, we do see an increase in activation as we see here in the plantar flexors. And so as a result of that, it could be again because of pain or it could be because of weakness. And in this case, after I look at that and I ask the patient, again, during the walking, how did it feel? Were you experiencing any pain or discomfort? And a little bit of discomfort and was experiencing some pain. And he's been in a level of pain for a period of time now. It's a low grade, especially after he gets up and is active. He's been previously told he has some degeneration in his spine, and at his age and his history of work, so his occupation was a lot of physical labor, including carpentry. And so he used to carry around and be in some challenging positions. And so I found that, at least in my experience, fairly consistent. So this activation pattern that we're looking at here is a combination between probably his lack of core stability and because of some of his pain, right? He does not want to engage a lot of hip flexion because then that has to be counteracted by the core stabilizers. And if they're weak, they're not going to be doing what they should be doing. Or if he's experiencing pain, he would rather create propulsion in the foot. And we're going to look at something interesting in the foot here in a moment. But so we can see that he is performing kind of typical as to some of these people with low back pain. So now we can go up here and we can click to the details view. And the details view is going to give us a little bit more information. And if I click on advanced, now we can look at this pronation supination. So you see up top here, there's a graphical representation. And then of course there's numerical values. A negative angle, a negative number means that they were heel striking on the lateral aspect of the foot. So let's look down here and we see that I can put my cursor over these large dots and it gives me the actual numerical value, right? That's the -5 upon heel strike. Well, this green corridor here is actually the normative value that we have found in our system. So what we're measuring here is we're measuring the orientation of the foot relative to the ground surface in the contact phase in a shoe. So what's interesting is sometimes that's why I'll do this at different speeds or in different shoes, because you will get some different answers. If you're going to have patients repeat, make sure that they're wearing the same shoes because you can get different data based on what the shoe may do. So for example, testing a runner in, and we do this on purpose, testing a runner in different shoes, we may actually use this whole process to make sure that they are wearing the appropriate shoe for performance, maybe for a reduction of injury. But we can see this is his normal shoe. And his normal shoe, I can see right here, is not being very good to him. So what that means is he has a left-sided ankle issue. It has a history of chronic pain and some injuries on that side. And so what happens is as soon as he heel strikes, he actually heel strikes in a very close to neutral position versus going on the outside. Well, what does that mean? Well, in the foot, it can mean a foot problem. And then, of course, a foot problem can become a knee, a hip, or a back problem. And again, he has a history of joint replacements on both sides. And he also has a history of injuries in this left ankle. We did some further assessment and very bad navicular drop. So this is a great way to show that, you know what, it's not just in the stationary position, it's also in the active position. despite, wearing the same shoe that he has on the other foot. So we see that he heel strikes in a relatively neutral position. Now, that's coming from the air and landing into the ground. So when I look at that, so I have a couple strategies. So we may look at a specific shoe that has a heel to it that can allow for a more optimal heel strike, right? Because changing the orientation of that foot can be a challenge, and it could be a little bit more than just an insert or an orthotic. It may take, something that's a little bit more rigid, something that assists the ankle and not just the foot. Okay. So we do know that he does have some issues with the orientation of his foot after he finishes that swing phase. So he actually heel strikes relatively neutral, and he pretty much goes immediately into and remains into a more pronated position or heel everted position, or at least lack of heel inversion. So what I want to do is I want to go back real quick and again show you that gait line. And so we look at the gate line, and so the gate line is representative of this. Now he is able to transfer and stay off of, the first and second ray. But what this is telling us is when he does come in contact with the ground, okay, he's too far over, right? And so that's actually going to create some strategies with regards to his walking. And in addition to, when we looked at his propulsion ratio, that he does have that strategy where he uses this foot even more than he should because he's lacking the ability to conduct hip flexor action, especially on that side. So he definitely has a lot of left-sided orientation things going on here, but yet his radicular pattern, also is on this right side, which is interesting. And that could be because of the shift in the way that he's walking as a result of changing the stressors in his lower lumbar spine. So these dots here show you the actual numerical value, and then you can see these amber colors, and they are going to be in amber, green, or red because they're going to say high or low. Now, we typically like to see some space in between here, one standard deviation, and we're looking at 0 degrees and -2 degrees. So he has a minimum and a maximum that are very, very close together. So this is very typical of people that have these chronic conditions. So he's worked really hard at trying to overcome that, is what it tells us. At least he has some variability and it's consistent, which is what we like to see. If you look over here, it starts to widen on propulsion. And so that could mean he's lacking a little bit of motor control as he goes into that. Not having tested him before, I don't know if this is new or if this is something common, but lack of motor control or things that cause pain. So if he is experiencing pain when he's walking, very common that you will see an increase in variability. In the foot progression angle, so this is the angle of the foot, the toes, the direction that they're pointing as you're going through the swing phase and you are heel striking into the ground. So 2 standard deviations in the normative range is between -1.5, -2, which is going to be a slight internal rotation, to 14 degrees of external rotation. So he's normal on both of those sides, but we do see, a 10 degree, which is definitely larger than the 6 degrees. Now, the way that we can explain that is actually right here. Okay. So if we were to correct that foot, and likely it's going to correct that foot contact time, and that's one of the reasons you're seeing a reduction in his foot progression angle here. Now, if it was 6 degrees and 6 degrees, I'd be okay with that, but they are dramatically different. And so that means he's asymmetrical by 40%, right? 40% difference here. And so that's going to be something to take into consideration. And we actually see that in both his gait line as well as in his pronation and supination here. Then we can look at, he has very large angles in in the toe off position and very small angles here. But part of that is going to be because he was taking very short steps. And so he wasn't having to reach out far because we only had him walking at 2 miles per hour. But what we see here is even at 2 miles per hour, he's really dysfunctional in his patterns. And so you can make a choice to move him up to 3. So for fun, another option is you can actually do a comparison. So in these 3 dots that are in the upper right-hand corner, you have options of renaming the analysis, export. Some people like to rename it based on the speeds or some other characteristic to make it a little bit more easier. So I'm going to click on compare. And let's see if I can choose the correct one. So it's automatically going to choose the analysis that you were originally looking at. And then I get to choose my second analysis. And if I did it right, it should show, yep. So now he's at 2.7 miles per hour. And now we can do a comparison between 2 speeds, right? So at the 1019, which is this one right here, he's got 35 and 32. And now we see 47 and 45. Right? 35 and 32, 47 and 45, right? So we do see some normalization. And let's click on the advanced. And so I especially want to look at and see at his 3 miles per hour, I want to see what that looks like, because remember that that's the average speed that most people should walk at. And here's what we see here. His swing time remains being relatively short. So it means he's pushing those legs really, really fast to cover that distance. Again, keep in mind he's on a treadmill, so it's going to look a little bit different. We do see that when we get him going a little bit faster, it changes a little bit in his heel strike pattern, but it's still consistent with regards to his strategy when it comes to hip propulsion. So now when he is moving faster, if we're challenging his core stabilization even more, right, you can look at his strategy right here, which was using the plantar flexors to move into that propulsion phase. And that, again, that goes along with what we thought or saw earlier. His patterns here. So we see that this was his 2 miles per hour. And we see that his pattern is actually pretty similar. So he's still overpronated, but look here. We can see that he is really variable once we lift that heel up. As he's transitioning from lifting his heel into propulsion, he has no control whatsoever. He has very poor ankle control, very poor ankle production of force and power, but it's because he's using it harder than he should be, based on the fact that he does not want to cause himself any more low back pain. We can look at his angles here. This looks a little bit closer, so maybe it was the speed that was causing that. But again, we're still off. And so this is, a real leading factor. This propulsion also another one, and that he takes really short steps, which is also consistent with people that have low back pain because they do not want to overextend themselves, requiring more stability and more forced counteraction by the torso, providing the reaction to ground reaction forces. We see that his clearance is good, and that's normal. He increases his toe off here. So that's a comparison, and that was like I said, 2 miles per hour and close to 3 miles per hour, as we can see right here. So I forced him into walking a little bit faster. And in some areas, it normalized a little bit, but we can see his swing time he's moving through swing time really, really fast. He'd rather be in stance time. And we can see that he really uses that strategy of not wanting to engage his core stability when he's going off of that left foot. And we can see that the increase in speed, it is not something that he's comfortable with. And in fact, it's quite variable. And it's, again, because he does not want to engage his core to counteract, those ground reaction forces as he's going through those steps. All right, so, oops, reload site. So keep in mind, we use this as an opportunity to look at a different case each time as we go through the analysis. And so next month, Rana, I don't know which one did we decide. If you were on here, you might be able to type in, or you did.
Yes, I'm here with you.
Oh, you made it. Woo!
Yeah. So the next webinar is on March 9.
Okay.
And if not mistaken, it's for elderly.
Okay. So keep a lookout for that, and that'll be the next case. And again, they're repeats. I mean, we're just going over the analysis, but I think it's interesting to see some different cases, and maybe I'll have a follow-up from today's case at some point in the future. Feel free to reach out to us. So if you have any questions or anything like that based on your analysis, or if you have any cases that you want to have us present on, please let us know, because we want to make sure that we're providing you all with the information that you would like to hear, and not just what I want to say.
I've shared our email on the chat, so education@digisol.com, in case you want to share anything with Chris, or perhaps a specific analysis that you would like to share with Chris and ask him some questions or discuss the details. We look forward to that, and we look forward to seeing you next month. Here, back to you, Chris.
All right, so let me just double check. I don't see any questions. Do you have cases for Park? Oh, do you have
I see one.
case? Yeah. So Georgie, I hope I pronounced that correctly. I would love to talk about that. So neurodegenerative disorders are somewhat near and dear to my heart, and so I think that's going to be a great topic that we will cover soon. To give you a little bit of an example, is with walking analysis and the use of artificial intelligence, Parkinson's is able to be diagnosed much sooner. So that gives us, as clinicians and the patients and families, an opportunity to intervene more quickly, and to improve quality of life, and to maybe slow down that process. So absolutely, we will have that discussion in the near future. Thank you.
And if I may add, that it would be very important also, every time you are measuring a patient or a person with a certain pathology, to note that pathology down, so that we can observe certain traits of a certain pathology. I mean, this will add up into the algorithm, and it will refine and fine tune the results so that we can really know what is specific of the walk patterns or running patterns of a certain pathology.
Yeah, absolutely. And that's a great opportunity to, I mean, it helps us all in healthcare, because although mathematical models are good, having real case uses really makes our systems better. And that's one of the advantages of our system is we also use real case systems. And Robin, for Parkinson's, is also really great to use a system to assess how changes matter. Oh, absolutely. I mean, even if we think about, and I know sometimes a lot of us may not think about it as much in physical medicine, but the medications that they're on having a positive or negative impact. So I had an older adult who was on certain medications, and it dramatically changed her balance. Not the obvious balance of standing still, but actually during walking, locomotion, and she went from being fairly normal to actually having a fall risk profile. And we were able to pick that up and use that to identify the issues, the changes as a result of medication. Absolutely, Robin. Good point. Do, 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 do. All right.
Okay,
So
seems no more questions.
cool. Well, thank you all for joining us. And I don't know if you heard, but Rana, we broke the record here in the United States. We hit negative 108 degrees Fahrenheit. Is the lowest recorded temperature here in the U.S., which is about negative 76 degrees
Wow.
Celsius last weekend. So, yay for me. It was cold. It wasn't that cold here. It was only about negative 41 degrees Celsius here where I live, but so
So
that's
stay
exciting.
warm, Chris, and everybody in the U.S. and out of the U.S. Stay warm.
Yes, we're warmer now. I think it's like what is it? +3 right now. Yep. Yep, it is. So what a change. What a change. All right. Well, thank you all, and I hope you have a great rest of your day and evening. And I look forward to seeing you all next time.
Thank you, Chris. Thank you, everybody, for joining us, and looking
Yes.
forward for March 9.
Yes. Thank you.
You would need to end the event, Chris.
It's not letting me.